probably have questions at the end. Right now, they're ready in both the labs. So we'll go to Oklahoma Art first to see where they are, and then from there move to Northwell. Okay, so can you go to Oklahoma Art to see where they are with the CTO case? Can we connect to Oklahoma Art? Okay. So while we are waiting, Dr. Chen, Mount Sinai, they use mini crush technique as most of their cases. I personally do a lot of mini crush. A lot of people use mini crush. Don't do the full DK crush. Just it saves a few balloons, a few steps. As long as you get kissing balloon inflation, do the pot. Do you think it will have a long-term impact on outcomes? We don't have any trial really comparing mini crush to DK crush directly. Any thoughts on that? I know you're a DK crush. You're the man who kind of invented that technique, but.
Oh, thank you. Thank you. Actually, many years ago, we started our DK crush event trial to compare mini DK crush. The DK crush is similar to mini DK crush because the protrusional size stem is limited to 2 millimeters. Compare a DK crush with mini crush.
So I meant not the mini, I agree with the mini DK crush. I meant the initial step of inflation without, after the crushing the stent in the side branch, you crush the stent in the side branch with a balloon, and then you do a kissing inflation with the crushed stent in the side branch. Instead of that, keeping two stents together and going with that, and then doing the kissing inflation and pot dot after that. So, thoughts on that?
Yeah, actually,
please go ahead.
I think the problem for mini crush is the quality of kissing balloon inflation, because 2 layers and it's difficult to find out the proximal to middle cell to recross. I think there's a key difference between DK and the mini crush. But for pot technique, after Tussaud technique, even though even pot is universally accepted, but so far there is no clinical data to support the routines of pot technique.
Thank you.
Thank you.
Are we Oklahoma ready? Can you switch your camera on in Oklahoma? Are they connected or through audio? Can you hear me? मैं कह रहा था उनको दिखा के चले जाएं, वरना उनका वैसे भी टाइम 6:15 का था राजीव का जो 3:30. बट उनका सर्च हो गया उनके एग्जैक्ट टाइम्स. चले फिर अगर वो नहीं आ रहे तो राजीव का कर दें. We can come back and ask. So since we're having problems with connection with Oklahoma, we're going to go to Dr. Rajiv. जो भी पहले कनेक्ट हो जब लगा दें. So okay.
Is that on?
Yeah. So we are. Hi. Where are we with the? So it seemed like you did an IVUS there. Can you hear us?
Yeah, I can hear. I can hear you. Can you see me?
We can see you.
Yes.
And
okay. Okay. So we crossed that, and then we got a 1.0 balloon, and that didn't cross, burst. Then we did a 1.5 balloon, that didn't cross, burst. But with those balloons, we were able to suck our guideliner in, and then took another 1.5, it crossed. Took the forced area and changed out for first took a samurai wire, samurai wire, took it all the way distally, and then changed out for a wiggle wire. So Bilal is working on it, and we'll show you what's going on. Bilal, you want to kind of tell us what you're doing? And would you grab that, come and closer, Jay? I'll move out of your way. So here's the iris. Can you see it pretty good? Huh? Make it bigger.
We can see the iris, yeah. Not the perfect pictures, but we can see, yeah. And it disappeared. Can we go back to the iris image? Focus on the iris.
What?
We're seeing Dr. Bilal's back right now.
So
Can you?
Can you press play? Can you press play? Yeah. Can you hear me? Can you hear me?
Travis? Yeah.
Okay.
Speak up.
So this is the intravascular ultrasound.
Can you all hear Dr. Saeed?
We can.
Okay, go ahead.
So this is the intravascular ultrasound. You can actually see it's predominantly fibrotic plaque distally. Measuring it, it's actually.
Speak up. Speak slower.
So, can you start it from the beginning?
No, you started from the beginning. Yeah.
So I think if you can quickly wind it up, we have to go to the other side. They have been waiting for us in Northwell. And we can always come back to you later after finishing with them if you to show the end result. But if you can quickly go with the iris run and your plan.
It shows the vessel to be at least 2.5 millimeter distally. It's predominantly fibrotic distally here.
Travis, stop it right here. Stop it right here, really quick, and then measure it. Give me a quick measurement. All right, so we got a measurement about 2.3 to 2.56. Okay.
And then more prominently, more proximally, you can actually see some calcification right there from 6 to 12. It's deep calcification. So rotational atherectomy is probably not going to help with this one.
Can you give me a measurement here?
And the arc is, just less than around 110. It's not like those circumferential more than 270, at least at this point so far.
Absolutely. Press play.
We agree with you. Yeah.
And then right there, you see this calcification. Again, it's all deep calcium.
Mm-hmm.
So IVUS actually helps you determine whether a rotational atherectomy or a CSI would work in this situation versus IVL. So right here, there was a calcified nodule at 9 o'clock.
Over here, you have like almost 360 degree calcium.
Yeah.
And the whole area is okay. So, Dr. Fahim Jafri, your thoughts? You would go with an IVL balloon here or go with rota? I mean, rota has an issue with the bend there. And
I think I would first take smaller balloons, make some room, and then IVL it.
Okay.
I think that's probably going to be the easiest solution.
I completely agree. So we've actually gone up to 2.5, but the big thing is I've got my guideliner way up there. So I have a pretty decent chance of getting our...
so what was the last balloon you used for dilatation, which you were able to get across and dilate it? I guess you will get the IVUS down and...
Okay, let's do this. So we did a 1.0, then we did, that got burst, then we did 1.5, that got burst, and they didn't cross, twice 1.5, but I was able to, we were able to suck the guideliner all the way in. So we got it up to the CTO, and then we were able to push the next 1.5 millimeter balloon across, open it up, then we've done a 2.5 millimeter balloon here also. So now we're going to put an IVL in. What do you guys think? Heather, 30, 35, 40, what's your lab?
What is that, the vessel measure over there? If it's, looks like at least a 30, if not more, probably.
So I think we haven't got a connection with the other lab. You are with us, so we're enjoying your case. You continue and keep us posted.
Guys, your vessel is not adequately prepped, you know. You really need to prep it more before you stint. You know, you really need to add another technology like shockwave, something beyond what you've done.
Dr. That's exactly what they're doing, trying to go with an IVL balloon. Shockwave.
Okay. So, all right. So, Dr. Haider Ali wants a 3.0, so we'll go with a 3.0. We probably can upsize it too. I would be comfortable using a 3.5 and even a...
You're getting this measurement of 3.0. I'm sorry, you're in the distal lumen right now. You pulled it. Where are you at the IVUS catheter? Which part of the vessel?
So we're done with the IVUS. We're going to put the IVL in. We're prepping the IVL. Jay, just show us the IVL preparation and stuff. Just
the measurements you got were from the proximal vessel or the distal part of the distal to the CPO?
All right, come on over to this side and show us the IVL preparation, Jay. Go around. Here. Yeah, 3.5. Let's go. Yeah, do you have a balloon up there or not? No, we'll go through. We'll go through. So we can even use the IVL balloon to suck your eyeliner in. If it doesn't work.
So just an update, we're going to have the inauguration at 8:15 p.m. So hope you'll all be able to join, and then the gala dinner is at 9:15 p.m. Following that at the rooftop restaurant in the hotel.
Next, I had Confianza opened up already. There you go. If this didn't go.
But you would use Quaco first.
Absolutely.
Right.
Yeah. So Heather is talking. So Heather has done a lot of CPOs with me, and he still keeps picking my brain. Can you guys hear?
Yes, we can.
Okay. So he's talking about how I got in. So we started with Peter XD, and he got stuck at a point. And so then I told them to go to Mongo, and they tried Mongo, and they got stuck. So then they asked me to come in, and I tried, and I kind of, if you remember, I told you that this is not going to go through because the seat.
Dr. Jauhar, Dr. Rajiv Jauhar, can you hear us in Northwell?
I can hear you.
You can, but we can't. Okay.
Can you hear us?
Can you switch on your camera in Northwell?
Can you?
I'm sorry, Dr. Khalili, they're asking me to talk to Northwell as well, just to make sure we establish connection over there as well.
What's he saying? Naman, can you speak slower so I can understand you?
So, Dr. Naim, we're trying to establish connection with Northwell as well, so just troubleshooting with them, communicating with them while you are with us. So you carry on with what you're doing and continue what you're doing.
Okay, so what happens is, we did Mongo, and Mongo, I felt it and didn't seem to be going anywhere, so I got a G2, a Gaia 2, and I tried a little bit, and it
So Dr. Rajiv Jauhar, if you can hear us, please switch on your camera.
So we're prepping the IVL.
Hi, it's Rajiv Jauhar. How are you?
We can hear you now. Can you switch on your camera, please?
The camera is on. I'm not sure what the problem is.
Can we switch over to them? Somehow they're not able to get connection with you. They're saying something at your end that they can't get your pictures.
Okay, we're working on it from here. Because I see you.
You guys see us?
And the whole panel.
All right. So can we work it out at our end here? What's going on?
Heather?
They're saying it's just probably you have your camera off. Is your camera on over there? And I'm talking to North.
Yeah, the camera is on.
Okay.
Now you can see what you have. take a picture.
We're trying again.
So you have a guideline there, not too much, right?
Yeah.
So apparently, they're saying everything is okay at our end. There might be some camera issue that if the camera is not on at your end.
We're doing it right now. We're trying again. 2 seconds.
Let's try again.
Sorry.
So your camera is showing a cross on your iPhone. They think you have to switch the camera button on your iPhone. Yeah, I think you're showing up now. So Dr. Naeem, we're going to switch over to the Northwell lab with Dr. Jauhar, and we'll come back to you to see your final result, okay?
Okay, sounds good.
Thank you. Doing great work. Really enjoying your case. Thanks. So,
Good
stage is
afternoon.
all yours, Dr. Jauhar.
I'm Rajiv Jauhar. Can you guys hear me well?
We can hear you well and see you well as well now. Welcome.
Perfect. So I'm Rajiv Jauhar at Northwell, North Shore University Hospital. I'm the chief of cardiology here. I have a terrific team in front of me. I have Yazin Ali, who's our CHIP fellow. Pervez Miraj, who everyone knows, is our director of the cath lab. Parija Shardilal, she's our interventional fellow. George, standing right next to me, is our tech. Damien is our nurse, and Bill is in the control room doing the monitoring, and Anthony is our IT guy. So we have an interesting case. As expected, whenever you have a live case, there's always things that happen. It's like a NASCAR ride. So we've had a lot of issues this morning with getting the Impella up, but I'm going to present you the case, and then we're going to talk about what happened. Next slide, please. So we have a 68-year-old gentleman who was admitted with a non-STEMI a few days ago, has a long history of diabetes, hypertension, hyperlipidemia, end-stage renal disease, on dialysis. He's on aspirin, metoprolol, atorvastatin, and insulin. Next slide. His EKG shows some diffuse ST changes. Next slide. His echo done in the after he presented showed an ejection fraction that was severely decreased at 25%. His anterolateral wall, anterior, mid-inferior, lateral, and inferior wall were hyperkinetic. He has no LV thrombus. Next slide. Normal RV size and function. We brought him to the cath lab a couple of days ago, and he has a mild left main disease, some circumflex disease, but a very tight proximal, appears to be very calcified, based on the fact that on both sides of the moving motion you see calcium, which is a classic angiographic sign of severe calcium, but diffuse distal disease. Next slide. His right was, this is again a picture of the ostium of the proximal LAD, which shows severe calcified disease. Next slide. And again, the LAD. Next slide, please. By the way, can you see the video as well?
Yes, we can. Thank you.
And he has an anomalous right coronary artery with a significant mid-right lesion, also calcified, which we use a JL4 to get into the right coronary artery. Next slide, please. So as we normally do, we took him off the table, had our surgical colleagues evaluate him. They felt that he was extremely high risk and was not a good candidate, given his STS score of about 12%. And after discussion with the patient and his family, a CHIP procedure was planned. Next slide. And so we plan to do this procedure, and we're thinking of the best technique and the best way to do this procedure. For the panel on there, I know my friend Javed Suleiman and my ex-fellow Atif Bashir, and I think Bashir Hanif is on the call too. I'm not sure if he's on or not. How would you guys tackle this case from a CHIP perspective?
So, comments from the panelists. Dr. Fahim Jafri is with us as well. Dr. Javed Suleiman. He was online with us. Dr. Rab, are you there?
Switch back to the 4-quad.
Yes, thank you.
Can we have a panelist on? Meanwhile, Dr. Naeem Engel, you want to make some comments? Yeah.
Thank you, Dr. Mohan. Definitely, it's a very high risk patient having EF of 25%. I wonder whether they've gone for any perfusion scan or not for the viability, because this patient is having 3-vessel coronary artery disease and with anstomy. So I'm not able to locate at which vessel is the culprit. The patient presented with anstomy. I'll definitely go to fix that first. And at the same time, I definitely go to look for any viability in the LED or circumflex territory to proceed further.
Okay. So the
And I
question
think that's
was,
a
do you
great
have any
point.
information on viability? I guess it's an ACS patient, low EF. You want to go for the most important vessel first, which is the tight LED. Probably that's what they're going to go for. But do you have any viability information?
Well, because he was having symptoms, that to me was our viability.
Okay.
Coupled with the fact that he did not have akinesis, but hypokinesis of his anterolateral wall, so that's why we were less concerned about doing a viability study. Normally, we would have done a viability study, but in this situation, we felt that the anterolateral wall was viable.
Okay.
So Rajiv, this is Tanveer calling.
Hi, Tanveer, how are you?
Hi, good. So what do you think is the culprit? Because you have multiple areas, okay? Obviously, the LED is most prominently by the SIR. You also got the right. And the other thing I need to know, what is the creatinine of this patient, okay? So, and how...
End-stage renal disease patient on dialysis,
Tanveer. Okay, on dialysis, okay.
Yeah.
So the multivessel disease, are you planning to work on all the vessels or just the LED and the circ right now? Because I think some of the disease does extend back to the left main. And I know you have an imaging catheter. Was that done after some degree of predilatation, or did you?
Yeah, I'll give you the whole history now, Tanveer. But exactly. Our thought process was first to work on the LAD and probably the circumflex, and then probably bring him back in the next day or so on the right, or maybe do all three, depending on how well it goes today. But we had a very difficult beginning to the day, so which I will show you in a couple of minutes. Javed, what would you do?
Hi, Fahim Jaffrey here, Singapore. I would lean towards doing the right first. Looks pretty tight. Get that out of the way, and then come back and do the LAD circumflex. Just because of the fact that at least if you get the right sorted out, you get a little bit more support. Wondering what your thoughts are on that.
Fahim, but does any data support your contention? I mean,
no. It's just something that's pragmatic. I agree.
It's artistic, right? I mean,
yeah.
Look, the reality is we are not doing the right first because we feel it's more complicated because of the fact that it's very anomalous. And we're using, like I said, we use the JL4 to get into the right. So we felt that the fixing the LAD would be a straight shot and would be the easier of the two, if that's such a word, because I think they're both pretty complicated. But our thought process was we're going to do all, but we're going to do the LED first. But again, it's artistic, and I don't disagree with doing the right first.
I guess a good thought, if you're coming to the left main, you want patron right while including the left main. But it's one of those things. LED is the most important vessel in this patient, the ACS who's coming. So,
would anyone have in planning this case? Would you have done imaging first? Would you have put a MCS device in? How would you have done it? We did it obviously a certain way. As you saw, we did do an impeller device. But in Pakistan, how would you have done this case? With a balloon pump or with no MCS?
So, the MCS is obviously not available, and yes, where it is available, it should be used with the ejection fraction of 25%. With these vessels, definitely impeller should be used. But in Pakistan, we use balloon pump. In this situation, balloon pump, and we have our anesthesia team in the room for a patient like this, and all the pressor support ready, so just be prepared to deal with the patient if he starts going down south while you're working on him. But that's the best we can work with. Any thoughts from the panelists in terms of these high-risk PCIs? Since we don't
here in Singapore, we would do the right and then do the left with impeller.
Would you have done all three in one sitting?
No. As I said, our approach would be to do the right first without support, and then come back and do the left with impeller. And as you said, there's no data one way or the other. It's just pragmatic.
I'm looking at
So
the femoral.
our thought-
They were able to get the impella up, with the femorals the way they look. We've seen.
So,
Oh,
as
boy, look
like
at
I
that.
said,
Yeah, look at
the unexpected is always expected
Yeah.
during a live case. And so when we started this case about an hour and a half ago, with the intent of being online at 9 a.m., obviously when we shot the femorals, we saw this. So my colleague, Dr. Miraj, tried every skill and technique he had to get up into the up the femorals, but was unable to with the impella sheath.
Did you shockwave it then? Did you shockwave your way up?
Who said that?
Tanveer.
Tanveer, you're shooting my all my.
Oh, I'm sorry. I'm going to get off there.
Tray.
I'm going to leave it to Pervez to ask you those questions. And hello, Pervez.
There's Pervez right there, right next to me.
That's an IVL.
So Pervez we did do shockwave. We shockwave up and down the iliacs, and with the shockwave, we were able to. We did 5 runs of shockwave, and we were able to get the impella finally up into the LV, and we are now running at a cardiac output of about 3 points. Can you zoom in into the impella? Into about a cardiac output of about 3.7. His pressure initially, when he came in the room, was about 80, and he had dropped to a pressure of 65. And so we felt the impella was a necessity in this situation. And once you put it in, the blood pressure is now running very stable at 120.
Just out of interest, if you were not able to get the impella up, then would you have just aborted and then tried an alternative access like axillary, or what would you have done?
You know, we do axillary here. I would have to check on this guy because he has 80 fistulas, but it is definitely a viable option. I think a balloon pump is probably not enough support in this situation, providing maybe 0.3 to 0.5 liters per minute. So I would probably not do that. But aborting, maybe what we would have done is what our colleague from Singapore said. Is fix the right first, stop, and bring him back after we have our peripheral colleague, Dr. Johnson Cox, doing our peripheral case.
Hey, Rajiv, Atif here. How are you?
Atif, my friend, how are you?
Good, good. So I was just gonna say, I think since Shockwave came out, I would be, a little more comfortable going with just a balloon pump, thinking that I can get away with, or if I think I can get away without doing atherectomy, if impalla's not gonna go.
I'm going to show you the angiogram today, Atif, and I'm not sure that would have been the best option for this guy. If you look right here on the first shot, I can't tell without imaging how deep is the calcium, how superficial is the calcium, whether there's a nodule there, and I'm not even sure I would be able to get a shockwave down there. I think maybe a hybrid approach with a CSI or roto and then a shockwave is an option. But I think shockwave by itself would not be a very good option here, given the amount of angiographic calcium and possible nodule.
So I guess
I think in these ESRD cases, you have to be ready to do atherectomy, and I agree. You can't go in hoping to get away with shockwave. It's almost certainly wouldn't even cross.
Yeah, as you all know, in the United States, we did not have shockwave, and you have much more experience in Pakistan and Singapore and the rest of the world than we do. But I can tell you my experience with shockwave has been, it's a very good tool if you can get the balloon across. That's for sure. But unfortunately, the balloon is just not compliant enough to get down in a lot of situations. So I'm a big fan of atheroablation in this situation, especially the Prox LED. Shockwave going up with that balloon, dissecting proximally into the left main is always a concern, especially with so much calcium. And so our thought process was that we should do atheroablation with either CSI or rotablator. And depending on, once we do that, then do OCT, which I will show you. And then after that, decide on the plan of action. Atif, do you disagree with that?
No, sounds great. So can you show the OCT images?
Very reasonable approach.
Hi, Rajiv. This is Javed Suleiman. How are you?
Javed, my friend, you're about 8 miles from me, so we should come over for tea.
I know. You're also in the office. So yes, looking at the angiogram, what I could see on my iPhone, I think all three approaches are fine. I mean, using IVL or using orbital atherectomy or rotational atherectomy. But what you said, putting the IVL balloon down will be difficult. Many a times it's bulky and it doesn't go that easily. Sometimes we have to fine tune it with a small 2O balloon and then put a 3O or 3.5 whatever balloon we need for the shock wave. But I think in this case it looks like if you are going for the LED, the best will be to do a rotational atherectomy with a 1.5 burr, looking at the angiogram.
I guess since you've done the imaging, why don't we look at that and then make the final decision regarding what therapy would be best?
I think here, lesion prep, I think on the last case, someone was mentioning that we didn't prep the lesion enough. And I think on this case, our thought process was, I think rotablator is a very viable option. We believe that the vessel is about a 3.5 or larger, and it's a Prox LAD. And given the size of the vessel and our desire to prep that vessel as much as we can and change the architecture, we actually went with CSI in this situation to really try to open it up and then be able to OCT.
Can you show the OCT images? Were you able to get the catheter down without problems in the proximal LAD? It looks very tight, calcified. You didn't have any problems?
Say it again, I'm sorry?
Were you able to advance the OCT catheter down through the lesion without problems?
We had to atherectomize first. We were unable to
so you atherectomized first and then you did the OCT, okay.
So, but, at least, the OCT will show us whether there's calcium fracture, how deep is that calcium. I mean, you guys all know that, the criteria we use, obviously, now is, the rules of 5, right? The 0.5 thickness, 5 millimeters in length, and, the arc of the calcium. And you see here really some very impressive deep calcium and superficial calcium. There is a dissection right there, probably from the CSI, but there's, and you see right there's right about 9 to 12 o'clock, there's a nodule that's probably shaved. And that was our initial concern when we did the angiogram, that if there was a nodule present, the risk of perforation is obviously much higher with a shock wave.
And what made you choose orbital over rotational atherectomy? We don't have orbital available over here, so...
So we use orbital here. My thought process is obviously to use orbital in larger size vessels. And given the fact this is I can't see the size here. It's about 3.5 proximal. We decided to do orbital in this situation. But I don't disagree with using rotational in this situation. I just feel like you'd have to go to about a 2.0 burr.
Okay.
Did you check and see if anything would cross the lesion first? I mean, one of the problems with orbital is that you don't have the front cutting effect, and so when the lesion is super tight, like it is over here, sometimes you run the risk the nose cone won't go in, and the crown just spins behind it and can cause a whole lot of damage. So I'm wondering how you made that choice, or did you have?
I think that's a great point. We did try with a 1.5 balloon, and we were unable to cross. But we felt that this was probably the best way. We were going to try with an OCSI. If that didn't cross, then we would have probably switched over to a rotational atherectomy, given the, I probably use a 1.5. We don't use 1.25 here anymore, because we've seen a lot of stalling with 1.25 burrs, and so we basically stick with a 1.5 or higher burr.
All right, so can you go over the... sorry,
this is Javed Suleiman again. I think orbital atherectomy, the CSI is also a very viable choice, especially given the proximal lesion and there's no tortuosity, anything. We are concerned more of if you go to mid to distal area, and also to a smaller size vessel. As you know that the mechanism of rotational atherectomy is more moving forward with an circular motion, and this one is more like oscillating.
Exactly,
and
because of
chances of perforation complications we see more often with mid to distal lesions. So this is probably a good choice for CSI or orbital.
I guess just as an argument,
Javed, the reason we did this
just as a
also,
devil's advocate,
because
they're
it's so
typically for a
tight,
tight lesion because it's forward moving with the rotational. You prefer rotational atherectomy versus orbital because it's sideways. But it worked there very nicely, and it's a large size vessel, so it's a good choice for it as well. But a lot of times those tight lesions, because of the forward cutting, they say to go with rotational. So what is your plan after the OCT? Are you satisfied? You've done enough? You're going to go with...
Hey, thank you.
I think, well, number one,
were you aware that Nick Parson was back in the ER? One of our patients from a week or two ago?
I'm sorry? Okay, so anyway, one of the reasons we also did orbital was, what I've seen a couple of times in my career is that when you have a very tight, very calcified lesion, and the rotational, if you're not very careful, it jumps forward.
Okay.
Sometimes you can get stuck and not be able to come back.
All right.
And so for that reason also we did orbital. I think based on the OCT and the fracture and the calcium, I think we have a very good expansion abilities. We're now taking what balloon is this?
3ONC.
The 3ONC balloon.
All right.
And we're taking a 3ONC and trying to expand it and see if it does expand. We will not be stenting this thing unless we see good expansion with the balloon.
Okay. And you're happy with
And we're going to come back probably into the distal left main.
So you did get a lot of cuts in the calcium there. You're happy with that in terms of that you're optimistic you'll be able to...
I think our prep is good. I think we only went to low speed. We didn't go to high speed because we have seen, just like Javed said, dissection distally with the high speed rotation, with the orbital atherectomy at 120,000 RPM. So we did the low speed, but I think with the OCT, we're very happy that the prep is going to allow us to expand that the stent. Do you all disagree or agree?
Couldn't disagree. Any comments from the panelists?
Well, that's good to know.
I agree. I don't use high speed with orbital. I mean, it's just, that's when you get the perforations.
Absolutely. And you know what the beauty of this was? That the Impella, there was zero budging of the blood pressure or the cardiac output with the CSI. Despite not fixing the right and having that circumflex lesion, his cardiac output and his waveforms remained stable throughout the whole CSI process. The concern obviously is that embolization with the particles going distally in someone with a low EF is always very concerning.
We have Dr. Shaolin Chen with us.
So you didn't see any uncoupling then?
We have Dr. Shaolin Chen with us. He wants to make a comment on the case. Please.
Absolutely. Hello, Dr. Shaolin.
Hi. Thank you very much. Just two questions. How much is the pulmonary arterial pressure and the PVR, pulmonary vessel resistance?
Okay.
Second question is that what's a balloon size of shock wave, 2.5 or 3.0? Thank you.
So he was asking about the balloon size, which was 3.0 they mentioned, I believe, and he wanted to know the hemodynamics, pulmonary vascular resistance. He wanted to know the you want to know the hemodynamics of the case? Yeah.
Did you do hemodynamics? His LVEDP was 34. We do not have a swan in.
Okay.
At this time, so I can't give you the PVR. But the PVR was normal earlier. Dr. Miraj just told me.
Okay, the right heart. Yeah.
Rajiv, on the OCT, did the plaque extend back to the left main or not? Because the osteocert looks involved.
Can you go back to the OCT, please, Anthony?
Yeah, that's an excellent question there.
Can you, Jimmy, can you go back? No, it didn't really. I mean, at the ostium, there's not that much plaque at the ostium.
We can't see the OCT run that you're seeing over there.
Can you see the OCT run?
Now we're seeing it. Now we can see it play. Yeah. So can you bring it back into the left main from the LED?
Can you go back to the left main? Yeah, back to the left main, please. So there we're in the left main.
Yeah.
I mean, there's definitely some plaque.
But it's looking.
But it's not significant. I think the lumen size is good enough. We would probably not step back into the left main. Does everyone agree with that?
Yes. Yes.
Yeah, minimize as much as you can.
I mean, there's definitely a lot of calcium between 9 and 3 o'clock, but it seems to have fractured well, and we put a stent in. 3.5 stent went in. Okay.
So after the 3.0 and non-compliant, then you went into 3.5. Were you covering?
We're going to cover just to the proximal.
Can you now zoom up the
LED.
angio image, because we are seeing the IVUS, the the
Can you go to
impella,
the image of the
console, and we are seeing the
angiogram, please?
hemodynamics as well. We just want to see the angio images right now.
Sure. Can you see the angio images now?
We can, but if they can just show that one picture, we're seeing all fours. It's really.
Can you make the one view, single screen, please? Do you see it now?
Well, we're seeing it, but it would be nice to see just the angio thing, so we can see it better. But
Anthony, just single screen angio.
Yeah, they're showing us everything.
Was there any concern for that diag jailing?
How about right there? You see that?
Yeah, we can see it very well. So there's a question regarding diag. I think it's got Timmy. We can see. Let's see the run.
There.
So diag is Timmy 3 flow. It is pinch, but I think yeah, it is significantly both of them. Yeah. So
would you have?
So there's a question from one of the panelists regarding the diagonal, and the stent needs better expansion.
We're going to expand. Again, we put the stent in a little distal. We're going to put another one proximal.
Okay.
A 3.5/23 sky point.
Okay.
But honestly, I don't think we're going to go after that diag. I don't think it's necessary. There's Timmy 3 flow in there.
Exactly right.
And we would probably leave it alone.
Okay. So I mean, this looks quite tight, but there was a, as we discussed this morning, is a lot of these if the Timmy 3 flow and patient is not having active pain from it, before you fix it, and the FFRs of about only 25% of these, which looks more than 75% stenosis of a significant FFR or hemodynamically significant. So.
Yeah, I mean,
I would just leave that diag. I wouldn't go.
Absolutely.
Yeah, just leave it.
That would
I
be
mean,
the
we
reason
know
to leave
from
it.
data
Most of them are not
that if you get FFR in the next couple of days, it's probably a little bit of spasm there, and I suspect that the flow rate's normal. Our rule here is unless it's a co-dominant system, we do not go after branches that have Timmy 3 flow. If you bring him back in a couple of days, like we probably will with the right coronary, I suspect that diagonal will be fine.
Likely so.
I mean,
so you put the stent to the ostium, right? The ostium of the LAD, or?
We're going to the ostium of the LAD. We're not going to go into the left main.
There's no indication to change the diagonal.
You can see right there. We're just at the ostium.
Yeah.
And as you know, with the sky point, it's mid marker as opposed to the onyx and the other stents, which are at the edges. So Pervez has been, and Yazin and Parija are careful to make sure you put it just at the ostium.
What stent did you use?
I'm sorry?
What stent did you use, and how much pressure did you go to?
It's an Abbott stent.
Okay.
It's the newer version of Sierra, Zion Sierra.
It's a new Zion Sierra, right? Yeah.
Okay.
And we're taking that balloon, the stent balloon, and just post-dilating a little bit distal. But again, there's been
you're going to dilate with an NC balloon, right? Or
I'm sorry?
You're going to post-dilate with a non-compliant.
Absolutely. Absolutely. Yeah. And the beauty of it is that the pressure and the cardiac output has not budged whatsoever with fixing the left main. We're taking a 3.5 NC. 3.5/12 NC balloon. And with that, hopefully we'll be done with this case. We will probably do another OCT run. And we're going to fix the circ today. And then probably wait for the right coronary till Monday. Today's Friday. Yeah, till Monday. Would anyone do all three in one sitting?
No.
I'm sorry?
No, right? Yeah. Would anyone have done all three, given the fact that we have the impella in one sitting?
I don't think so, but any comments? I wouldn't do it. I mean, the plan was initially you thought you might do the circ in the same setting as well. I guess you just LED now. You're going to go with the circ.
We are. We're going to do the circ today.
So LED circ.
Once we get off the call with you guys, we'll finish the circ.
All three in one setting. I think nobody would agree to that. All of them are nodding to staging the ride.
Given the fact that we have quite a bit of peripheral disease and difficulty getting the impella up, if the patient is stable and everything goes according to plan, I may lean towards fixing all vessels, but I think bringing him back and doing the case for the last vessel without mechanical support, I think is reasonable too. I don't know, putting him through another impella access is going to be...
Sorry, I don't hear you very well.
So that's a good thought that, you know, he already has impella in and there was difficulty getting it up to try to fix the right in the same setting. But I guess with the left system open, probably, are you going to go with the impella next time as well? Or how much time are you going to give him before you go for the right?
No, I think for the right, we'd probably try to go radial and be done.
Yeah.
Probably would not do this femoral. Right. The reason we went femoral is Anthony, will you zoom into the groin, please? And as you know, I mean, I think in the last case they showed it, we went single access with the impella device. So we had the catheter going into the impella device, so one access for everything, which was perfect. But for the right, we'll probably go radial next time. Not probably, we will try to go radial next time.
Can you just quickly show us the picture after the postal? We have Dr. Ihtisham ready to give the talk, so or we can come back to you.
Okay, perfect. Yeah, we'll take a last picture and then we'll be done. And we thank you from Northwell Health.
No, thank you for showing that is great case, great learning from it.
Yeah. So we'll take one more picture, guys.
So can you show the angio thing?
Just one final...
Go to the angiogram.
And then we'll do one final angiogram, and then we'll let you go to the next talk. Bill, you step to the left, please? Oh, we are. All right, here's one of our shots. We'll take two shots, one caudal and one cranial.
All right.
So I think that's a very nice result.
Looks great.
Obviously, we're going to do a little CT afterwards. I think you have to go, and we'll make sure it's well opposed. And the cranial shot to look for Timmy-3 flow. And look at the diagonal that my colleagues have mentioned. I think I would be able to sell on this with this result and move on to the next vessel. Everyone agree with that?
Yes.
Yeah,
look.
Great result. Excellent learning case. Thank you so much.
Thank you.
No, thank you, everyone. I hope you have a wonderful conference, and next year I hope to be there live in person with Dr. Miraj.
Yes,
good to see you, Pervez and Rajiv. Good to see you both.
All right, Tanvir. Nice to see you at New Orleans a month ago. Yeah. Bye, guys. Thank you all very much. Thank you, team.
So we'll switch over to Dr. Ihtisham and he's going to go over the 2023 guidelines in interventional cardiology training statement, and he was one of the authors for that, and from Sky. So welcome, Ihtisham. Noman here.
Hi, Noman.
Thank you for taking the time to do this. So the stage is yours, and can you share your slides?
Wonderful. I guess somebody else is sharing, and they
somebody else is sharing, you said? Somebody else is sharing. I guess you have to do screen share on your own from there. And you have 10 minutes for the talk. Yeah, we can see your slides now. Thank you.
Can everybody see my slides?
Yes, we can.
Perfect.